of Michigan. He's a chronic pain researcher and he knows a lot about fibromyalgia and chronic fatigue. So thank you for speaking to us, Dr. Clauw, and it's nice to have you again. So take it away anytime you're ready.
Well, again, I didn't intend to give a lecture. I'm just going to do a Q&A today. I'm sure, I mean, Cindy, you sent me a whole bunch of questions. If you want to ask some of those, and I'll answer in front of the entire group, you can do that. Other people can, but I give talks 3 or 4 times a week. It's super easy to find my hour-long talk on the internet, and I thought it would be more valuable to this group to answer individual questions that people. It's a lot harder to find me to answer one-on-one questions than it is to go on the internet and find the hour-long talk that I give 3 times a week. So I'm not giving a talk. I'm just responding to questions that your group asks me. And I put in the chat, I put a link. There's a bunch of the videos of my talks on our website, our Chronic Pain and Fatigue Center website, all sorts of videos, but including ones, again, recently where I've given talks. So
I do have a question unless someone wants to go before me.
Oh, go ahead, Mary Lou, you can ask your question.
Okay, Dr. Clauw, I remember, I think it was your last visit with us, your last talk, that you talked about Flexerol and cyclobenzaprine, and I was influenced to take that. So it's diagnosed, given out in the lowest 5 milligrams, but I cut it in half. So I take it like right before bed. But I do remember, I recall you saying, if my memory recalls right, that you said to take it, I thought you said 3 or 4 or 5 hours before you go to bed. Is that correct? And if that is, why would that be?
So yeah, everything that you said is correct. People often will start at 5 milligrams or even 2.5 milligrams. There are 5 milligram generic tablets that you can get if even 5 milligrams is too much for you. But just like other drugs, cyclobenzaprine / Flexeril tends to work better if you take sort of the highest dose for that for you doesn't have any side effects. So often, if you take Flexeril a couple hours before bedtime, you can take a little bit more of it and not be groggy or foggy the next morning than if you take it right at bedtime. Because if you take it right at bedtime, there's still some of that's in your brain when you're otherwise trying to wake up. So I generally recommend that people take it 2 to 3 hours before bedtime. But the only reason for that is to sort of minimize the side effect of morning grogginess that a lot of people have with that class of drugs. There is actually a company that is doing trials of a form of Flexeril that would go under your tongue, and it dissolves immediately, and you would do that right at bedtime. And they did 2 trials, and they probably are going to get it formally approved for use in fibromyalgia in the next couple of years. But if they do, that'll be way more expensive than getting the generic Flexeril and taking a 5 milligram tablet. So I'm only saying that is that the fact that they did these trials that were positive, that is going to lead to FDA approval in all likelihood, just sort of reinforces the fact that the drug is helpful, but you can get it right now. You don't have to wait till that company gets the drug formally approved and you get the under the tongue version of it.
Okay. I guess I wasn't clear on the part that you said about 2.5 milligram or 5 milligram, because when I told my doctor that I wanted it after, you were speaking about it. And so like I said, it's prescribed in the 5 milligrams, what I get, I cut it in half. My doctor told me start out at, the half of a pill. And so I haven't changed that. And I've been taking it for a number of months, quite a while. And so I still take that half, like 2.5 milligram. So were you saying like you should take more? I guess I wasn't clear on what you meant.
Yeah, I didn't say it explicitly, but now I will, now that you asked me to. It would be worthwhile for you to try to go up to an entire 5 milligram tablet and just see how you feel. If 2.5 milligrams of Flexeril helped you somewhat, 5 milligrams could help you more and not really have any discernible side effects. So as with a lot of other drugs, again, you may or may not know this, but when Flexeril was first approved, it was approved 10 milligrams 4 times a day. So the FDA is okay with you taking 40 milligrams of Flexeril in a day. So it's not a safety issue to go up from 2.5 to 5 milligrams, because we know even taking, way more than that is safe. It might make you very groggy, but it's not going to harm you. But I think when we use it for fibromyalgia, we just use a nighttime dose. And what it's primarily doing is helping improve the depth of your sleep, the quality of your sleep. And for that reason, what a lot of people, when they first go on cyclobenzaprine, they start at 2.5 milligrams. It really does help their sleep a lot for the first week or two, but then they almost become accustomed to that 2.5 milligrams. And if they don't go up on the dose, that 2.5 milligram continues to help them, but it doesn't help them as much as if they went up to 5. And then sometimes people will go up to 7.5 milligrams. I always have people say, when I used to do clinical care, I don't see patients now, but I used to use this drug a lot when I was seeing patients, and I would say, go up to 10 milligrams at bedtime, but maybe for you, the right dose is 2.5 or 5 or 7.5 or 10. It might take you a while to figure out what the optimal dose is for you so that you get the beneficial effects of the drug without the side effects.
Yeah, that's a good explanation. I appreciate that. And I do think that's what it helps me on, is the sleep. Because I'll go to bed and I'll say, I might not get to sleep right away, but I took that pill, 20 minutes before, whatever. And then before I know it, I'm just out. And then next thing I remember is when I wake up, the next morning or something. But I don't sleep long enough always. Maybe I should try it, increasing it. That might help the length of my sleep. That's part of my issue. So
yeah, and then the other thing, and this isn't just for you, it's for anyone else that might try a similar class of drugs. The first day or two you go up to 5 milligrams, you may actually just transiently feel, oh, that's a little much. I'm a little groggy the next morning. Just try it for a couple days, and often that wears off. And then you say, wow, 5 really is working better. I sleep an hour longer. I, have a little bit more energy during the day. But you judge. You know how you feel now at 2.5 milligrams. After you go up to 5 milligrams, give it a little bit of time and then just sort of see, does that seem like that dose is working better for me because it's giving me a deep sleep for an even longer period of time? Or does 5 seem like it's a little too much for me because I'm groggy in the morning now and I'm just going to go back to 2.5 milligrams?
yeah, thank you. I really appreciate that, because I'm certainly not an expert on drugs. I don't really take many at all. So, I mean, I'm not a pharmacist, so to speak. So thank you.
Well, yeah, that's why I come and answer questions, because none of
Yeah.
yeah. So
Exactly. Yes, I appreciate it. You do a good job on, describing it and taking it apart in segments so I understand it. Thank you.
Hi, Diane.
Go ahead, say it. I dare you. So, low dose naltrexone. What's your thoughts on that?
I think it's well worth trying. I think it's very safe. It doesn't seem to have very many side effects. I'd put it almost in the same category as Flexeril, low dose Flexeril. I think it's that everyone with fibromyalgia should try it, because if it does work, it usually is it's pretty well tolerated. It might not work in you, and in which case you don't take it, whether that's Flexeril or low dose naltrexone, but it's not going to cause a serious side effect in you like other things you could try for, that might be a little more off-road with respect to treatment. So I think it's worth trying. It seems like the dose that most people end up on is either 3 milligrams or 4.5 milligrams. And again, it's the same kind of thing. You try it. If it helps you, keep it. If it doesn't, discard it. Don't keep using a treatment that isn't clearly a benefit to you. It doesn't, even if it has discernible side effects, it's just better to each treatment, try one at a time and evaluate, is it helping me enough that I should continue it? And if so, then it's going to be part of my regimen. And if not, I'm going to get rid of it. Because far too many people with conditions like fibromyalgia end up just like accumulating medications that they don't even know if they're helping or not. It's just, well, my doctor put me on this, my doctor put me on this, and all of a sudden they're taking 8 drugs. And maybe part of why they feel crappy is a lot of the side effects of those drugs.
Hmm.
So I
Right.
think people should carefully evaluate each of their treatments, almost in the same way that I've gone through first cyclobenzaprine and now low dose naltrexone. Um, does it seem to be unsafe? No. It's like, so well worth trying. And then after you try it, it's really up to you. Does it make you feel well enough that it's worth continuing? And if so, keep taking it.
It does.
Yeah. Well,
It does.
you and about a
Yeah.
third of the people that take it. So
It's kind of a weird thing the way I had to have a pelvic ultrasound, and I have a very difficult time tolerating it because of fibromyalgia. And so the doctor sent me for physical therapy, and she just said, just started talking to me about the fibromyalgia. And she actually suggested me to go on it and explained it to me. And I was like, okay, no morning backache. That was the goal, was being able to get myself out of bed instead of my husband. And I would say within about 6 weeks, I was down to maybe once a week having a hard time getting out of bed that fast. And I started out at 2.5 milligrams, and just because of some manufacturing issues, I went up to 5 milligrams because they said, everybody told me, don't worry about it. And I haven't noticed a difference at all in going up, but cutting those pills in half was a pain in the butt. And that's why they were just crumbling and it was a waste. So that's why I kind of went up to it. And at least the manufacturer that I get it from, the compound pharmacy, they don't make a 2.5 milligram, so you have to cut it in half. But everybody I ask about it, doctors, nobody knows about it. That's why I was wondering, how long have people been, doctors been prescribing?
well, there have been a couple of small studies, but they haven't been large definitive studies. So, even when I write all sorts of review articles and things on treating fibromyalgia, you have to be circumspect about low dose naltrexone because we certainly don't have nearly as many trials of something like low dose naltrexone as we do drugs like duloxetine, where Lilly did large studies in fibromyalgia, or pregabalin, or Pfizer did large studies, or even cyclobenzaprine, where again, there's been a series of companies that have done studies with cyclobenzaprine. Low dose naltrexone, we have a couple really small trials. And so as a fibromyalgia expert, I know about those trials, but those trials,
Okay.
you wouldn't, a general primary care physician would be totally unaware because they're not in big journals at all. They're more in, journals that we would be aware of as fibromyalgia researchers.
Okay. Okay.
Well, Dr. Claw, I had a question in the chat from Cheryl, my vice president. I guess her microphone's not working for some reason, but she wanted me to ask you if hemp CBD can help with chronic pain and fibro.
Yeah, so let me give you like a mini talk about cannabinoids because again, there's a lot of misinformation about cannabinoids. So
Mhm.
CBD is cannabidiol, and THC is tetrahydrocannabidiol. So those are the two major constituents of what we used to call marijuana, but marijuana, it has slightly racist undertones, and now the preferred term is cannabis. So those are the two constituents of cannabis that are being best studied right now with respect to whether they work in pain or not. And we have a lot of NIH funding specifically to study different cannabinoids in different settings. We have a study in osteoarthritis looking at CBD and THC. We have a study in multiple sclerosis looking at CBD and THC. And then we have a study in the perioperative period to see if giving people CBD a week before and a week after surgery will reduce the amount of opioids they need when they get their surgery. So we're really interested in cannabinoids. But one of the other studies we have ongoing is when the state of Michigan legalized cannabis about 5 or so years ago, which was about 10 years after the first medical marijuana law, the second law that actually made it legal. In that law, they put a statute in where some of the tax dollars on cannabis would be distributed for research on cannabis. And they set aside $40 million in taxes from the sale of cannabis in the state of Michigan. And we applied for and got about $10 million of that to do research on cannabis. And those trials are ongoing, but the way the state law was written, because most of the people that helped lobby for legalizing cannabis in the state of Michigan were veterans, like U.S. veterans of military service. They were veterans that were doing the lobbying, so that when they wrote that statute about that the $40 million would be given for research funding, all of that research had to be done in veterans in the state of Michigan. So the two studies we're doing in veterans of the state of Michigan, one of them is doing almost exactly what I'm doing for you right now, which is to say, you're saying you want to try a cannabis product to treat your pain. Please give me some guidance on, like, where do I start? What dose? What route of administration? Where do I get it? Because my doctor knows nothing about this, and I can't get any good quality information from my doctor because my doctor thinks that cannabis is the evil weed from hell because he watched, Reefer Madness 30 years ago. He knows nothing else about, and so I give lectures about cannabis all the time, and I start with like 1.5 minutes of Reefer Madness just to start with that. Like a lot of doctors in the state of Michigan, that's their knowledge about cannabis. They know nothing, and they're inappropriately afraid of it. And they actually don't even know to counsel you that cannabidiol or CBD, we know, is really harmless. It's very safe. It doesn't cause you to get high. When Cheryl wrote hemp CBD, there's two forms of CBD in the United States right now. The CBD that is derived from hemp is entirely legal in all across the United States. That is not, but if someone extracts CBD from cannabis, from the marijuana cannabis plant, that still is considered a Schedule I drug. But the CBD is exactly the same. It's chemically still CBD. So the first thing that you should be aware of is hemp-derived CBD and cannabis-derived CBD are both CBD. It doesn't matter, except one is more legal. Both of them are legal in the state of Michigan, but only hemp-derived CBD is legal throughout the entirety of the United States. Like if a state doesn't have a medical marijuana law or something like that, the only CBD someone would be getting, in Florida, in Georgia, whatever, would be the hemp-derived CBD, which is fine. It's CBD. They wouldn't be able to get THC because that comes only from cannabis. A long time ago, because hemp is used for industrial purposes, hemp was specifically bred to not have the THC in it so that you could grow massive amounts of hemp and use it for weaving and things like that. So hemp, it was actually a farm bill that was passed about 3 years ago in the United States that made hemp-derived CBD legal in all 50 states. So that's a long-winded way of saying it doesn't matter what your source of CBD is. In the state of Michigan, you can go to a dispensary and get CBD, and that CBD probably came from cannabis. And they pulled the CBD out of the cannabis and they got rid of the THC to give you the pure CBD. If the hemp-derived CBD that you get from Walgreens or CVS they start with hemp and they pull the CBD out of that. But CBD is CBD. It doesn't matter where you get your CBD. So that's the first thing I want to emphasize, that there's two sources of CBD, hemp and cannabis. It's CBD. When it says, you do want to make sure that it tells you how many milligrams of CBD is in it, so you know like how much CBD you're getting. But now the stuff you get at Walgreens or CVS or whatever that is hemp derived will tell you, it'll be pure and it'll tell you how much CBD it has in it. So now let's talk about CBD versus THC and using it for pain. CBD is, and like, I should finish the story that I started to tell you. One of the studies that we're doing with that state money is doing a cannabis coaching program, almost like what I'm doing right now with you, to say there's people in the state of Michigan that have chronic pain that would like to see whether CBD or THC is helpful to them, but they don't get any guidance. No one tells them how to use it. And what we think is happening is a lot of people are overdosing because they're going to a dispensary that's primarily catering to recreational users. Recreational users mainly want to get high. So most of the dispensaries carry the really high THC forms of cannabis. And because that's what the recreational users want. They want to get high. But you're medicinal users. You don't want to get high. You want to take just enough THC to help improve your pain, but not so much to make you high. And so, again, what we would do is counsel you to first try CBD alone to see if that helps your pain, because that's super safe. That it's not psychoactive. There's hardly any side effects. The main side effect of CBD alone is your wallet, is it's not inexpensive. And your insurance, it probably isn't going to pay for it. It's not unless you have a rare form of epilepsy, and CBD is an approved drug for, childhood epilepsy. But as soon as you start using THC containing cannabis products, that's where you add all of the safety problems. It does make you high. It is psychoactive. You shouldn't drive, all those other kinds of things. And what we've learned about that in the pain field is a really low amount of THC works better for pain than a high amount of THC. A lot of people that are not getting the appropriate guidance, they go to a dispensary, they get dispensed some really high THC strain of cannabis. They try it and they get super high and paranoid, and they say, I'm not going to do that again. And it's like, well, you took 10 times more than you should have. You should have tried by taking like 2.5 milligrams of THC at bedtime, or maybe at most 5 milligrams of THC at bedtime in a gummy bear. But that's how you should try it, in a very low, very controlled setting. And take it at bedtime, because most of the people that are legitimately using THC to treat pain, they're not recreational users, they're pure medicinal users, do find that almost like low dose cyclobenzaprine, that the primary benefit of it often is a low amount of it at bedtime helps you get a better quality of sleep. But start low and go slow with CBD. Doesn't, again, you can start at 50 milligrams and then go up to 100 or 150 milligrams. Again, the main side effect is cost of taking a higher dose of CBD. But THC, start at a really low dose and go up very slowly, so that you don't overdose, especially if you've never used cannabis, or the last time you used it was 30 years ago and you're sort of cannabis naive. That like 2.5 milligrams might be all you need. A really low dose might be all you really need. Maybe then eventually you go up to 5 milligrams. But if someone who was a regular like cannabis user, recreational cannabis user, 5 milligrams of cannabis would hardly do anything to them. They'd be chewing on 20 milligram gummy bears to get high.
Cool.
Somebody's trying to ask a question, but they're muted.
Yeah, I think Diane. She doesn't know, I think.
There. I thought I did unmute it. One of the things that Dr. Clauw didn't say about hemp and cannabis is they're actually two different plants, like tulips and scalloped tulips. Same family, but two different plants. They don't even grow them near each other because if they do, the cross-contamination can kill the plants and all that kind of stuff. But it's a separate, hemp is a separate plant, and there's even CBD plants that are grown CBD with no THC in them, the plant itself. Because I grow that and I make creams and stuff. I've made cream with castor oil that I use on my eczema, and it has cleared up my eczema and cleared up. I broke out with shingles, and I had both of those cleared up within a couple days using it. So don't be afraid of trying CBD cream. It can do wonders for pain and skin conditions. Even my dermatologist is kind of blown away by what that has done for me compared to prescriptions that are extremely costly, and because I have a blood disorder, can be very dangerous as well. And
the other thing people should be aware of along the lines of what you're saying, though, is all the CBD that people can get legally, the law is in order for it to be CBD, it has to have less than 0.3% THC. Even less than 0.3% THC, if you use a ton of CBD, if you take a very high amount, could change a urine drug screen positive. So if you are in a occupation that does urine drug screens for cannabis, be aware of the fact that even though you're taking CBD, if you take enough of it, that 0.3% of THC could turn your urine drug screen positive. So that's mainly now for certain vocations where they're still doing random urine drug screens. Most employers have stopped doing this because it's legal in the state of Michigan. We're not trying to get rid of it, but you should be, just again, as a general point of information, when you're counseling people, even though it doesn't have very much THC in it, it has a tiny, tiny amount. It can have a tiny, tiny amount that's enough to turn a urine drug screen positive.
I just have a quick question. I hopefully you can hear me.
I can.
Good. I take hemp CBD without THC at night, and I do have an issue with my liver, like a fatty liver. Is there any problem with taking hemp CBD with liver?
Not that we know of.
Okay.
Probably would, you probably, after it seems like you've been on it a while, just maybe make sure that your liver function tests haven't become elevated or more elevated since you've been on it. But as long as you're getting, again, if you have fatty liver and they're sort of following that along and things like that, as long as you don't see we don't know of any hepatotoxicity or hepatic problems with CBD. But frankly, it hasn't been well enough studied, to say that with certainty. So it is metabolized in the liver, so it theoretically could have some liver side effects. But it's being so widely used now that I think we would have seen it if it was going to be a problem, any kind of liver toxicity. And again, I'm just telling you, some of you know this kind of stuff, some of you don't. CBD is now approved for use because it was shown to be effective in several rare types of childhood epilepsy. There is a form of CBD called, the drug is called Epidiolex. It's just pure CBD. And that's the drug that, again, the kids with rare forms of epilepsy use. It's super expensive and everything like that, but it's no different than the CBD you're getting from hemp, quite frankly.
Is that legal throughout the United States? That new form, the Epidiol?
Yeah, in fact, in these NIH funded trials that we're doing, the simplest way for us to do the trials is to actually use Epidiolex, because that's an approved drug in the United States. Whereas if we tried to use, let's say that we wanted to use for our CBD, if we wanted to use CBD that was extracted from cannabis, that's still a Schedule 1 drug. We'd have need to get a Schedule 1 license from the DEA. But because this is how stupid the fact that cannabis is still Schedule 1 is. When pure THC is given as a prescription drug, which is Marinol, that's what we use for our trials, is Marinol, which has been available for 15 years. It's approved to treat post-chemotherapy nausea and vomiting, and it's approved to treat AIDS-induced like appetite loss. But that's pure THC. It's pure synthetic THC. It's been approved. In our NIH trials, where we're in osteoarthritis multiple sclerosis, we use that form of THC, and that's a Schedule 3 drug. Pure THC is only a Schedule 3 drug, which is like lower scheduling than like, oxycodone, hydrocodone, like opioids are Schedule 2, are higher scheduled. So with even pure THC, we know that it's not very addictive. It's a Schedule 3 drug, but the DEA has been so stupid about descheduling it that researchers like ours have figured out workarounds so that if we want to give people CBD, we give them Epidiolex because that's an approved drug. It's super easy to give them that versus a Schedule 1 drug.
Stupid.
Dr. Clauw, are there any new drugs out that are better than Cymbalta, gabapentin for fibromyalgia, or doing any studies on any new drugs? I think I'm asking this question for myself and Kathy. She was going to ask you that as well.
No, I think it's a lot of the advances in the treatment of conditions like fibromyalgia has been how effective a lot of the non-drug therapies are. When I wrote a review article on fibromyalgia in the journal JAMA, and it was published in 2014. And if you look at the table of drugs that was in that JAMA article, it's not different really right now than it was then. So what's dramatically changed is the evidence for all sorts of different non-drug therapies in the last 10 years. So, acupuncture, yoga, Tai Chi, mindfulness, 5 different types of cognitive behavioral therapy, not just one old pain-based cognitive behavioral therapy. There's been an explosion of knowledge about all the different non-drug therapies that can be helpful in conditions like fibromyalgia. And I would say that's been more of an advance therapeutically than that there have been like new drugs that have been identified. And really the preferred approach right now is that people try a lot of those non-drug therapies, maybe even ones that they were dismissive of in the past, because it's like, yoga's not going to work for me, or acupuncture is not going to work for me, or Tai Chi is not going to work for me. It's like, well, the trials have been done and they work for a lot of people. So a lot of things that maybe you were, maybe that you thought wouldn't work, or your healthcare providers weren't crazy about. We've even changed the name. A lot of those therapies used to be called complementary and alternative therapies. And the implication, if you call them complementary and alternative, is you're using those like after you use other things or instead of other things.
Right.
But if you really look at the evidence, like how well those work, those are the first line therapies, getting people sleeping better, getting them moving more, getting them, more active, trying different movement therapies like yoga, Tai Chi, different types of cognitive behavioral therapy. If people have a lot of trouble with sleeping, cognitive behavioral therapy for insomnia. If they've had a lot of trauma in their life, there's trauma-informed cognitive behavioral therapies like emotional awareness therapy, like Howard Schubner et al. Do in this area. So, but that's where the big advances have been in the last 10 years. Is now there's like 20 different non-drug therapies that work in fibromyalgia, and most people haven't tried all of those. And that's what people should really be thinking of is like, what are one or two of those that, I just like to give it a try. I never gave that a try. I never gave that a try. They're all safer than any of the drugs, and that they work better too on average. It doesn't mean that it'll work in you, but most of them work in about 1 out of 3 people. So, when I'm giving talks to groups of doctors instead of groups of patients, I say pretty much the same thing. It doesn't really matter. But I say, that if you're taking care of people with chronic pain, the biggest thing you can do is encourage people to try 2 or 3 new non-drug therapies that they have never tried. That they knew they existed, but they've never tried them themselves because they didn't have access to that therapy or they didn't have any awareness that it might be helpful. But that's probably the biggest thing, that the biggest piece of advice that I can give for people with conditions like fibromyalgia is, yeah, there probably will be another couple drugs approved in a couple years, but don't wait for the new drugs. There's a lot of new treatments that are not drug treatments.
We need to get insurance companies to help pay for some of those.
That is a huge problem. I spend a lot of my time.
They pay for the drugs.
The payers. I spend a lot of my time talking to payers and telling them that this is almost every talk that I give. The last slide that I give is all of these therapies that are available to our veterans patients and our Department of Defense patients. Those systems figured out about 7 or 8 years ago that the evidence base was there, and they do offer all of those therapies that I just talked about. But people that have private insurance, even like really good insurance, Blue Cross Blue Shield, great insurance, are not going to have access to most of those therapies. They're going to have to pay out of pocket. Then they make those therapies more expensive and sort of unapproachable to a lot of people.
I have a question. The cognitive behavior therapy, that would be like speaking, counseling with someone, right?
Yeah, but you can get a lot of that web-based. We have a web site called Pain Guide. It's all one word, painguide.com. And it's based on cognitive behavioral therapy, but you do it on your own. You go to different chapters, and maybe 1 week you work a lot on your sleep, and 1 week you work on, and it's got a lot of different treatments in there that you can directly download videos to learn how to do mindfulness or learn how to do acupressure or things like that. So that website, that Pain Guide website that you can go to freely and go, spend out time in it, is now being tested in many NIH trials as like as a way of getting people some of these non-drug therapies, but getting them directly to patients without you having to, pay an acupuncturist teach you how to do acupressure. Acupressure, you self-administer it and you can do it on your own. Yoga, there's a thing in our thing about, little videos you can download to learn some, or mindfulness or things like that. So a lot of these non-pharmacologic therapies, if we can make them more accessible in a web-based format or an app-based format, we try to do that. That's a lot of the research, a lot of the NIH funding that our group gets is for developing newer and better versions of websites and apps and things like that, so that patients don't have to pay out of pocket, don't have to go even leave their homes. They go to a website like this, and they can just directly then access some of those therapies.
Oh, thank you.
There's also a way in the website of tracking. If you really want to use this website and personalize it, there's a way that you can put in at the beginning. You create your own username and password, and then you sign in, and it allows you to track your own symptoms and put in like what treatments you're trying. And then we can't see any of that data. We're not in any track. We're just allowing people to follow their own progress in the website. So if you go into the website, if you just go to the website and look at it and don't put in a username and password, you won't be able to track your own symptoms. But if you do put in a username and password, when you come back to it, it'll allow you to say, okay, I'm going to try acupressure, and I'm going to take some, I'm going to see what my pain score is now and my fatigue score and everything like that before acupressure, and then I'll come back and redo some of these surveys 3-4 weeks later after I try one of these things that's on the website. But our attempt with this website is to both make some of the therapies directly available to you in the website, but also the ability to track your progress as you try therapies in the website. So this is all that the website was paid for with philanthropic funding, but we're testing the website with NIH funding.
I had another question unless someone else needs to go before me. Okay, I wanted to know, do you think I mean, my mother was 96 when she passed away, and it's been 20 years maybe, but I wondered, years and years ago, we didn't know about fibromyalgia. No one, the name didn't even exist. Do you feel that this existed years and years ago? I mean, maybe even in the late 1800s or whatever back. Do you think this was there then and no one just knew about it? Or what's your opinion on that?
Yeah, it was.
Uh-huh. Okay.
I mean, you can go back. There's famous people like Alfred Nobel, the guy that was the basis of the Nobel Prize. If you look back at his journals, he clearly had fibromyalgia. You know, there's other famous people that pretty clearly, you know, again, if you look back, they've had fibromyalgia. We also know this historical perspective occurred, like I'm old, and so one of the first conditions like this that I studied was the Gulf War illness, the people that were deployed to the first U.S. Gulf War. And when they first came back sick, it was called Gulf War syndrome. And then it was changed to Gulf War illness because we realized it wasn't a specific syndrome that was only seen in the Gulf War. It looked exactly like fibromyalgia, chronic fatigue syndrome, but it was triggered by people being deployed to war. It just like you can get fibromyalgia after a motor vehicle accident or after a COVID infection. There's like things like that can trigger the development of fibromyalgia. But after the Gulf War, like when the Gulf War illness first happened, like the military is like, we've never seen anything like this before. This is like, and then military historians look back and it's like, this happened after World War I and World War II, and the exact same symptoms were called shell shock. And it happened after the Civil War, and the exact same symptoms were called soldier's heart after the Civil War. So it's not that the symptoms didn't occur after other wars, it's just that the attributions were different. The way of thinking about what caused them was different after the Civil War, because in the 1860s, we actually still thought that the heart was more the center of the human body than the brain. So like if a condition like affected all these different areas of the body, then you would call it soldier's heart because it was like a circulation problem rather than a systemic brain problem. Similarly, shell shock was because, you know, they primarily identified this in people who had like PTSD and severe, you know, psychological sequelae of war. But it happened, we saw after the Gulf War that people didn't have to have PTSD, that just, you know, deploying them to war and disrupting their normal sleep routines and exercise routines and stressing them out, like laboratory rats, did make some of them develop sort of fibromyalgia / chronic fatigue like illness that was called Gulf War illness. But if they had that in the general population, that would have been called fibromyalgia or chronic fatigue syndrome.
Okay, well, thank you. That was very interesting.
Speaking about COVID, have any studies been done in regard to people that have had COVID and maybe have gotten fibro, or has the fibro gotten worse for those people that have had COVID in the past? I mean, I've had COVID a couple times since.
It's becoming more and more clear. Several of us wrote an article 4 months after the pandemic started predicting what long COVID would look like, and that's what it looked like. But the initial research efforts into long COVID were totally misguided. You know, it was a continued viral infection. It was all this. And the NIH spent a lot of money barking up the wrong tree. But now the entire sort of long COVID research community is finally now coming around to the fact that this does look exactly like sort of chronic fatigue syndrome, fibromyalgia, that can be triggered by things like Lyme disease, Epstein-Barr virus. We've known from the past that other types of infections can trigger this, and this was just yet another in a long line of infections that can trigger it, but we didn't get it right away, like usual. It's like there wasn't the historical perspective and we didn't understand it. But now, like most of the treatments that are being tried by the NIH in the big long COVID treatment networks are things that would work for things like chronic fatigue or fibromyalgia. This is now finally how that, but it's taken about 4 years or so for that, the thinking to come around and like what really is causing this.
So down the road, do you think that'll help with funding for research?
It is. There are now more, like the NIH is funding like post-infectious research and things like that because it'll and the other there has been a big increase. You haven't seen it yet as patients, but starting about 6 or 7 years ago, the HEAL initiative, the big increase in NIH funding that was both for addiction research and for pain research has infused about an extra $1 billion a year into the NIH for pain and addiction research for the last 5 years. That's going to help a ton. We get a lot of that money. We don't get $1 billion, but we get tens of millions of dollars. And those studies are actively going. Those are the biggest, best studies that have ever been done in the pain field by a long shot with respect to just what that funding allowed us to do. But those studies are just completing now in the next year or two. And then we'll be analyzing data and trying to identify new treatments based on what we learned. But as taxpayers, you should be somewhat reassured that, this is the first time in my career that I can say that the US government probably is now spending appropriate amounts of money on funding pain research. It didn't until the addiction problem and the opioid problem sort of forced their hand in doing this. But it's now, again, that it's a lot of additional funding that went into pain, and it's going to have good downstream consequences for patients.
Doctor, I'm sorry, I'm coming into this late, but I got an article from the Cleveland Clinic, and they mentioned something November of this year, anxiety, depression, and fibromyalgia linked to osteoarthritis and rheumatoid arthritis. And there's also talk that maybe they're using methotrexate. We had a member of our Fibro group, I don't think he's online today, but he tried ketamine IV form in a hospital. He was feeling good, but they wanted to, make it so he could take it at home. Once he took the medication at home in pill form, it did nothing for him. So, and he's been a long time Fibro person. I've had, low thyroid and trying to lose weight, same kind of fatty liver thing too. And I don't really want to screw my body up too much. I didn't do the Lyrica. I didn't do the gabapentin. It just didn't seem to work for me. I had almost like a form of glaucoma after taking, the pain medications. And I'm just trying to exercise and just do things on my own. And I'm looking for help when I go to an internal medicine doctor, hoping that he'll even talk to me this Friday. So thanks.
You had a lot of questions in there. Let me take a couple of them. The first is we do know that in addition to some people having, like fibromyalgia, and that's their main problem, 30% of patients with osteoarthritis or rheumatoid arthritis have fibromyalgia as well, which is way higher than the rate of fibromyalgia in the general population. So we know that having a condition like osteoarthritis or rheumatoid arthritis makes it far more likely for you to develop comorbid fibromyalgia. You still have rheumatoid arthritis, but you have fibromyalgia on top of it. You still have osteoarthritis, you have fibromyalgia on top of it. So that we know that occurs. We don't treat that with methotrexate, though. No. That we would treat the rheumatoid arthritis component with methotrexate, but not the fibromyalgia component. That's a anti-inflammatory drug. Now, ketamine is a different story. Ketamine's a different story. Ketamine's a psychedelic. It's got a lot of other properties. It is being used to treat pain. It's sort of a mess. It's sort of the Wild West. Is that there's all sorts of ketamine clinics that are using it, but there's not a lot of evidence
Mhm.
that it works. You're probably not going to get third-party payers to reimburse for it because there's not a lot of good data that it's
Yeah.
helpful. And so again, I think it still needs to be better studied. One of my trainees is studying ketamine right now for low back pain in a veterans study, but doing good quality research to see if ketamine is helpful for chronic pain. But most of the work that's been historically done in ketamine is used it more so for acute pain rather than chronic pain. And this practice of ketamine clinics and people getting repeated infusions of ketamine is dangerous unless and until we know, at least that it works. And then do we know how safe it is to be getting ketamine that often? That's again, it's not a drug that has been typically used in that way. Having said that, if some of ketamine's property, if ketamine does help, and if some of ketamine's properties are because of the psychedelic properties of ketamine, we just finished a pilot study of psilocybin in fibromyalgia, magic mushrooms. We think psychedelics might be promising in fibromyalgia, but again, we're doing it as rigorous research. We're not like, setting up a clinic and say, come one, come all.
Yeah.
We're going to give you this dangerous drug over and over again because we think it's helpful. It's 2:00. I probably could take one more question, but I have to get going.
I just have a quick question in regard to your research. Where can we find out where your research or what studies are coming up and if we can get involved in them?
Just go to our website. There's a place in the website for if you want to participate in research studies. There's a place to indicate that.
Okay.
Um,
Thank you.
But our website has a lot of really good information on it. We try hard to keep, like I just posted a couple videos recently of talks that I gave. One was a rant about opioids, about all the problems associated with chronic opioid use, that have nothing at all to do with addiction or overdose, by the way. So again, we try. I mean, we're mindful of the fact that me and most of the people in our research group get a lot of our salary paid by taxpayer dollars because we have so much NIH funding. And we think the reason I do this is I think that again, it's a responsibility we have as researchers that get public dollars to do research to try to let the taxpayers know what that has found and try to give better guidance. But we try hard. We can't influence the clinical care enterprise at the University of Michigan. And it's not a great system to get care for fibromyalgia. I don't even know where to send someone with fibromyalgia in Michigan medicine, but we do the best we can on the research standpoint to keep putting out better websites and videos and information. But that website has a lot of information on it. If you haven't been there, spend some time, download some of the things, try that pain guide website because there's everything that's on the website is very evidence-based. You're not going to get anything on there that is unproven.
What do you think of that swing care company?
I think it's good. I was one of the authors of that study. It's a commercial entity that's figured out a way to make money while giving you therapies that have been shown to be effective. But that study was published in Lancet, which is a leading medical journal. So
There's a couple women in Sharon's group that are seeing doctors in that swing care practice.
right. They have licensed people in the state of Michigan. You can get that care now. It's all that. But again, the more and more, I think over time, there's going to be more and more ways to get some of this non-drug therapy, like right now, swing care sort of figured out a model so that they can get paid for giving you that kind of therapy or that kind of care. Okay, I got to go. Cindy, it usually Zoom sends me the recording in a couple hours, but then I'll have to send it to you like in something like Dropbox because it'll be a massive file, but then you can somehow make it available to your members.
Oh, sounds good. I don't know if you wanted to upload it to YouTube or I don't want to just share it to anybody. I just wanted to get your permission, of course, because I asked my speakers.
I don't care. You can share it I mean, I let anyone share anything, any slides or any videos of me. as widely as they want. I mean, there's nothing that we talked about unless the individual people wouldn't want their names on YouTube. But again, I certainly am, the spirit of this is, if this was informational, then it'd be better for more people to hear it than less. So.
Yeah.
Well, thank you so much, Dr. Clauw, and everybody. Thank you for coming today. We're gonna hold on tight. We're going to our
Thank